The next speaker is fabulous. She has so much energy, this person, and she is really very influential worldwide in terms of what she does in her research. Kristine Yaffe is the professor of psychology, neurology, and epidemiology and biostatistics, all big words, right, at the University of California, San Francisco. And she was recently named the first holder of the Roy and Marie Scholar Endowed Chair in Psychiatry. The reason she's all these things is it's always nice to have prestigious names and prestigious positions, but it's because of what she does. Kristine has done enormously valuable and important epidemiological research. That is research that allows us to look at populations of people and understand what affects the risks of things like dementia, when dementia is certainly one of her major interests and one of her major areas of research. And a lot of things that her work is revealing is, as I said earlier, not only allowing people, organisations like Alzheimer's Australia to tell people what they need to do to lower their risks of dementia, but she's also, the work that she does informs basic science and allows basic scientists to think about the sorts of things that might be going on in the brain. She'll be talking a bit about diabetes, for example. And a lot of scientists, including myself, have started to wonder about insulin in the brain and what its role in the brain may be because of these understandings. And so the two inform each other very strongly. But anyway, having said that, I'll let Kristine speak and look forward very much to what she has to say about the risk factors and for dementia.
Thank you very much. I'm so happy to be here. It's my first trip to Australia, and I arrived yesterday morning, and so far, so good. I had a wonderful evening with Bryce, and I can say that the Australian food and wine certainly rivals that of the Bay Area. So I'm delighted to sample the rest of the Eastern Australia cuisine as well. It's really already been such an inspirational morning for me. It's so inspiring to hear Ida Boutros and all the work you are doing here in this country. I think it's really, you will become a model, I think, for the rest of us. It's really great. I want to switch gears a little bit now and talk about some of the things you've been hearing. So I do think there's great hope. What are things we can do? And again, it's important to realize it's not a one-to-one correspondence. So you can't do these things and necessarily prevent Alzheimer's, but you can lower the chances of having this happen. And I think we'll talk a little bit about some future steps, and it's truly an exciting time. As Bryce mentioned, we have a lot of work to do, but we've come so far, and now we can actually try and implement this and see how this improves the care of people with Alzheimer's and hopefully reduce the risk. Okay, so as you've heard, and this is true worldwide and certainly in Australia, if we do nothing, if things go the way they're going, we think there will be a tripling of the incidence and prevalence of Alzheimer's disease. And so this is extremely important because all of us will be affected by dementia and Alzheimer's, whether it's as a loved one, as a caregiver, as a patient, as society. We will all be affected by this disease. So it's extremely important that we do not just sit back and do nothing. We need to mobilize. And again, as you've heard, this is not a trivial cost, both a direct cost in terms of what's being paid, but also indirect costs. In other words, the cost on the caregiver, what kind of stress, physical burdens on the caregiver, the amount of possible employment lost, et cetera. And this, not surprisingly, is often disproportionately affected by women. So women are usually the caregivers, and some of these indirect costs are again, disproportionately carried by women. Bryce mentioned this, what could be the effect, not even of preventing per se, but by delaying. If we could delay the onset of Alzheimer's by a year or two, there could be huge impacts downstream, resulting in about a 13% reduction in the prevalence of dementia in 35 years. if we could even delay it more, such as 5 years, then it would be even a greater decrease, a 30% reduction, because, of course, these are all exponential changes. We have had some efforts in prevention, and so far they've been fairly disappointing. I won't go into great detail, but there have been some trials with antioxidants such as vitamin E, vitamin C, estrogen, as you remember, what held great promise as a possible prevention strategy, ginkgo, and nonsteroidal anti-inflammatory drugs, or NSAIDs. All of these looked very promising. Their big trials happened. As Bryce said, we tend to mobilize quickly when it looks like there's something helpful, but none of these have borne out. So it's been a bit of a head-scratching time, and I think we're now regrouping and being able to offer some promising strategies. What I'm going to talk about in the next half hour or so is where we are now and what looks very promising, with a big emphasis on cardiovascular disease risk reduction, obesity and metabolic disease, and of course being active, both physically and intellectually active. Why do we care about cardiovascular disease? It turns out that Alzheimer's disease actually has a big vascular etiology. They go together. And this is true in both the pathophysiology, but also in the fact that when people are diagnosed with dementia, they often have several things going on. So they may have Alzheimer's disease, but they may also have some vascular changes in the brain. And we think that these are synergistic, that they go together. The other important thing, of course, about cardiovascular disease is many of these things are modifiable. You can do something about them. And, of course, if you do something about them, they could benefit the body and the brain, as Ida Boutros so elegantly told us. What are some of the things we're talking about when we talk about cardiovascular risk reduction? Well, certainly high blood pressure or hypertension. That's one of the most common cardiovascular disease risks. And we know that there's a very important connection between hypertension and dementia, particularly in midlife. It gets a little more complicated as somebody gets older, and I won't go into the reasons, but certainly there's a very big connection. We know that the brains of people with hypertension tend to have greater changes consistent with Alzheimer's disease. We know that there's some trials that have been done doing antihypertensive drugs, and these may have a beneficial role. This is a complicated slide. I'm going to be showing a couple slides like this where you see on the bottom a logarithmic scale, and in this case, anything to the right suggests there's an increased risk associated with treatment, and anything to the left, a decreased risk. And as you can see, the bottom line here, this is when you statistically add all these things together to sort of say, okay, what's the whole field showing you? And you can see that in the trials of antihypertensives, there tends to be a protective effect against getting dementia. So these are adding all these things, different trials, but it looks very promising that if you are treating better hypertension, that maybe there actually is a protective effect. Now, what about diabetes? Diabetes, as Bryce mentioned, is really a fascinating connection with the brain and with Alzheimer's. Some of my colleagues somewhat jokingly refer to Alzheimer's as type 3 diabetes, which is sort of a joke, but in fact, maybe not so much, because there's a really interesting connection with diabetes and Alzheimer's disease. We know that the diabetes, of course, can affect risk of stroke. That might be large vessel strokes or even small little strokes in the brain, lacunes or white matter changes that one might not even know one has. But then also there's a very important role of glucose toxicity. So elevated glucose per se we think is damaging to neurons directly. And then of course this complicated relationship with the insulin and Alzheimer's disease pathology. So insulin regulates the beta amyloid, and beta amyloid of course is critical at some point, we don't know exactly, for the role of Alzheimer's disease. This, again, is that kind of figure I showed you before with all the different, these are all the different studies that have been done. In fact, there are others as well looking specifically at Alzheimer's or vascular dementia, but these are the different studies on the risk of diabetes and dementia. So if you look at the bottom line here, you see this over here suggests there's an increase, almost about a doubling of risk of Alzheimer's disease and dementia associated with diabetes. So what do we do about diabetes? Well, there are a number of trials ongoing using diabetes medicines actually for Alzheimer's disease. So mostly with people who don't have diabetes. There's a trial of metformin by my colleague at Columbia University for people with mild cognitive impairment. There's some trials at looking at lifestyle intervention with people with diabetes. There was a very interesting study by Suzanne Kraft using intranasal insulin to look to see whether this improved cognition, and because of the very promising results, she now has a much larger, big randomized trial that's just getting started. I do want to remind people we need to be careful, though, because one doesn't want to be too aggressive treating diabetes, particularly in the elderly, because hypoglycemia, lowering your blood pressure too much, could also have a downstream harm in terms of dementia. And this is a study that we recently published here showing that this bidirectional association, that if you have hypoglycemia, you also might have an increased risk of dementia. And so it's very, very important to not be too aggressive. We think that the best strategy for a lot of these cardiovascular risk reduction is in midlife, in middle age, and maybe late life, but not waiting till 80, 85. That may be a time when a different strategy has to be taken. What about obesity? Obesity, of course, is very closely linked to diabetes and to some of these other cardiovascular risk factors. And you can see in Australia, as in many parts of the world, we are really in an obesity epidemic. So extremely important for the body, for heart disease, but also we think for the brain. One doesn't think of obesity or fat as being necessarily that harmful. But it turns out that fat is actually an active organ, some people say, that in fact it produces many kinds of proteins and hormones that can be dangerous to cognition. So we know that there can be inflammation, for example. There can be changes in other things, dyslipidemia, hypertension. We think some of these proteins that go along with fat can also cause insulin resistance, and there's a vicious cycle with cognitive aging. Some of my colleagues have done some very important work showing that body mass index, again, probably most likely in midlife, so when people are middle-aged, you can see that the higher the body mass index here, the cutoff traditionally is 27 for obesity and 30 for morbid obesity. You can see that as this goes up, this is the increased risk of dementia. And then, interestingly, there's some work showing that your waist-hip ratio, so another way of showing are you an apple or a pear, that the apples are more in trouble when it comes to their brain volumes, in particular the hippocampal volume, which we think is so important for learning and memory. Now, these cardiovascular disease risk factors tend to cluster together. So people, if they're obese, they tend to be more likely to have diabetes, high blood pressure, high cholesterol. They go all together often. And we did some work showing that with the metabolic syndrome, which is a constellation of cardiovascular risk factors, that if people have this metabolic syndrome, 3 of 5 of these risk factors, that they have a much increased risk of dementia, as you can see here. And in particular, it seems to be very closely linked to inflammation. So there's something about inflammation and cardiovascular disease that works synergistically on risk of dementia. What do we do? Well, we know that these cardiovascular diseases are very important for the brain. And I think, as Ida Boutros said, it's time for us to make these linkages. When I give talks, sometimes I try and remind people about this thing called the neck, that the diseases of the body are linked to the brain, and that we need to really be aggressive at understanding this, that it's not just about the body, it's also about cognition. We need to try to target those people at risk for new trials. We also need to think about when somebody's being seen by their GP to not just be taken, they need to be looked at very carefully for heart disease, but maybe they should be screened for cognitive aspects as well. Be screened for dementia so that if it's picked up early, maybe more can be done. And also, there's a vicious cycle because if somebody has chronic diseases and they have dementia, it's harder for them to then take care of those chronic diseases, and around it can go. Just a slide about smoking. I'm not going to talk too much about smoking, but just to say that it used to be thought that smoking might actually be protective against Alzheimer's disease, and that's because of the nicotine, and nicotine can be somewhat beneficial in certain modalities in terms of learning and memory. But it turns out that, of course, smoking, because it's not just about nicotine, but it's about a lot of harmful substances, we now know that, in fact, smoking is, in fact, associated with increased risk of dementia. And some of those early studies, in fact, were funded by the smoking companies. Surprise, surprise. So now that's sort of the air has been cleared, we can see that it in fact, is a risk factor. Okay, I'm going to turn a little bit now towards physical activity. And just like, and they're not independent, of course, just like we're in the beginning of a obesity epidemic, we're also, I think, in the middle of a sedentary lifestyle problem. So a lot of people, and this is actually data from Australia showing that by age, so this is across the ages, broken down by men and women in yellow, that there are a lot of people, over half of people are actually not doing enough physical activity based on guidelines, based on sort of recommended guidelines of activity. Now, this work is so interesting. This is now work that's quite old. This was from 1999, and I think this has been one of the most interesting findings in neuroscience, and that is using mice models. These are mice, and they were in different types of environments and activities. It turns out that if mice are either physically active, so they're on their little treadwheel, or they are in a environmentally challenging environment with lots of new toys and new colors and stimulation, that they have greater number of new neurons in their brain, which is sort of incredible. And I think this is incredible for two reasons. First of all, it gives us the opportunity to maybe do something, and it also tells us the brain is much more active and plastic than we thought. We used to be told that you're born with all your neurons, and then every time you have a glass of wine, some of them die, and then that's that. And now we know it's much more complicated. That the number of neurons may go down, but in fact the brain is capable of changing and growing, and there are new neurons, particularly in the hippocampus, that can form even in late life. So I think that this is one of the most interesting and encouraging results in the past decade, because you can imagine then that this would give us new hope to either have a reservoir or try and change the brain in response either to early Alzheimer's or to increased risk of Alzheimer's. So there have been quite a bit of studies in people as well. This is work from my colleague Eric Larson in Seattle, and he looked at exercise and dementia risk. And as you can see, that in this group who exercised 3 times a week or more, they had a less likely chance of having dementia compared to this group. From some work from Dr. Lautenschlager from Australia. This, again, is a very important trial showing that in people who had mild memory complaints, that by doing exercise, there were improved results in terms of cognitive function. So very, very promising, and many people now have replicated this or are about to try and launch big trials. I think physical activity is one of the most promising strategies that we can offer patients and participants, and I think now finally a lot of attention is being paid on this. We've also done some work on this in terms of cognition. This is some work we did very early showing that in older women, the more walking they did, the less likely they had of declining on cognitive testing. So this was not necessarily running a marathon, right? We're not asking people to do something that is not realistic. This is walking. So a lot of people like walking for exercise, and this was just increasing the amount of walking, or in this case, being more active. We had little wrist actigraphs, and we could measure how much activity people did in the course of their day. So not sitting still, but being active. And it doesn't necessarily have to mean going to the gym. It could be doing one's chores or gardening or walking. So I think this is extremely exciting. Another area of great promise is this idea of being active in your brain, being engaged cognitively. And we think that cognitive activity is extremely tied to the risk of dementia. There have been a number of studies that show that the more educated, that IQ, that your occupational achievement, your head circumference, interestingly, or doing mentally stimulating activities, or even more interesting leisure activities, all of these have been connected to risk of dementia. So I think it's very interesting. And the theory is sort of twofold. I think there's two parts of this. One is that maybe your brain is you're born with a brain that is able to do some of these things, and that therefore there's some sort of a reserve. But the other idea that gets back to those interesting mice models has to do with the idea that the brain is changing and growing. And so by using your brain, by learning new activities, you can actually either change the brain, get new neurons, or actually strengthen existing networks. And that by doing this, you could have a buffer so that if Alzheimer's disease starts to occur, you're better able to withstand that. And I'm going to show you some very interesting data that I think fits this. There have been some trials. These are really interesting trials trying to train people in different domains, cognitive domains, either in this case memory, reasoning, or speeded tasks. And it turns out that by doing these trainings, you can see benefits even after a year. So a year after the training, the people seem to be better in these functions. So I think this, again, is very exciting. One of the questions is, well, can if you get training, can it extend to other functions? And we don't quite know that. But I think this tells you that by learning things and by being trained, you can actually increase your function, and this could be a buffer. This is some work we did recently, and we studied participants who had, we looked at their amount of plasma beta amyloid. So as you know, with low beta amyloid in the blood or in the CSF, we think this is a problem because the beta amyloid is actually going more into the brain, and so the low amount of beta amyloid in the blood or in the CSF is a risk factor for getting Alzheimer's or in the setting of Alzheimer's. So what we did was we looked at people and we divided them into low plasma beta amyloid, which is the at-risk group, or high, and then we looked to see how much education they had. And very interestingly, the people in blue who had higher education, in this case high school or greater, graduate or greater, they seem to have a buffer against this risk factor of the low plasma beta amyloid. And yet in this group with the lower education, the low plasma beta amyloid did worse, is what we would expect. So again, this idea that there could be a reserve, a buffering against the risk factor by education. And this is some work by Risa Sterling's group at Harvard, which is sort of the same thing. Instead of looking at the blood, what they did was they looked with the PET scans. They looked at beta amyloid in the brain with the PET scans. And what they found, again, these are all people who had these brains with amyloid, but if they had a high level of reserve as measured by a reading test, a literacy test, they did not show as much effect of the amyloid being in the brain compared to the other groups. So I think this is tremendously exciting. This idea that even if you have amyloid in the brain, there's this buffer because of your education or your cognitive reserve. So where can we expect this to go? I think more and more we're going to be seeing these trials. Just last week, a good friend and colleague published in Neuron this result of a trial of cognitive activity, so using computers to stimulate your brain, and that seemed to be very helpful in the setting of age-related cognitive changes. So I think we're going to see much more about this. I confidently suggest to all of my patients that they're active physically and mentally. And I'm often asked, well, does it matter what I do? And I say, listen, if you don't like bridge, don't try and play bridge. Do something that you like. Do something where you feel engaged, where you're learning. And I don't think we know. I don't think there's one thing. I think the idea is more that you're learning new things and you're making new connections. I want to now turn to some other areas that I think we don't quite know as much about, but hold great promise. And I think we'll be hearing more about them in the future. One of them is sleep. Now, what does sleep have to do with Alzheimer's disease? Well, we know that if people have advanced dementia, they can have major alterations in their sleep. So people often who are institutionalized may have real disruption in their sleep-wake cycle. There could be wandering. There could be real changes in their sleep. And it's not been clear what's chicken and egg, right? But this very interesting work by David Holtzman's group has shown some fascinating connections between Alzheimer's disease in rodent models. So in rodent models who are sleep deprived, these are they don't have dementia and they're sleep deprived. What they find is that there's much greater amount of A beta in the brain, suggesting that there's something about sleep deprivation or sleep alteration that could actually be a risk factor for Alzheimer's disease. And we looked at this in a population of older women. What we found was that by carefully doing polysomnography, so these women had polysomnography, very good sleep performance measures, we found that sleep-disordered breathing, or sleep apnea, was associated with about a twofold increased risk of developing either MCI or dementia. This was all-cause dementia. And then we wanted to see, well, what is this? Is it because the people are up all night, or is it because in sleep-disordered breathing, people stop breathing over and over for small amounts of time during the night? So we were concerned that maybe it had to do with a lack of oxygen going to the brain. And what we found is that we think it is really more the latter. We think it's the oxygen loss, that the brain is not getting enough oxygen, and somehow this then in turn leads to a higher risk of dementia. We also have done some interesting work. This was led by a colleague, Greg Tranat, and what we found was there are circadian rhythm shifts. So for people we all have a circadian rhythm, a sort of 24-hour clock. And what we found was that in people who had a shift in their circadian rhythm, that it happened, it was more delayed, that these people also had an increased risk of developing either MCI or dementia. So these, I think, are very intriguing, and I think we're going to learn much more about sleep in the future. I think others are starting to really look at this. Traditionally, sleep has been looked at in younger people. So people are deprived of sleep for 3 days, and then they're given all these tests, and guess what? They don't do as well. But people haven't really made the connection with Alzheimer's, and I think that's really about to shift. And I think I encourage people to have their sleep quality looked at, and if they do have something like sleep apnea, which is quite common, about 40% of older adults have sleep apnea. So if they have sleep apnea, this should be treated, and because we want to avoid that reduced hypoxia, the reduced oxygen to the brain. What about depression? We know, including some very important work from Australia, that depression is probably a risk factor for Alzheimer's disease. It's never been clear whether it was maybe an early symptom of Alzheimer's or whether it was a true risk factor. But this is some work from Yvette Chaline's group showing that the more untreated depression, the smaller the hippocampal volume. So again, suggesting that there's this interesting link with depression and the hippocampus and memory. This is one of those slides again, and you can see, wow, what an incredible number of studies. So people have really been looking at this, and it turns out, I think, pretty much conclusively, we think depression is a risk factor for Alzheimer's. I think, again, it's still a little unclear whether it's a risk factor or an early symptom, but they're clearly linked. And this is some work that some colleagues have done at Columbia where they actually treated people with depression and cognitive impairment, and they found that by adding a cholinesterase inhibitor for the cognitive problems and an antidepressant seemed to actually work synergistically. So I think we'll see more about this. Another fascinating area that is receiving attention is the role of
antidepressants on actually beta amyloid in the brain. So these are PET scans. Here you can see, and several groups now have shown that if the antidepressant use seems to decrease the amount of beta amyloid in the brain. I'm, again, not sure we know exactly what's chicken and egg, but I think it's a really, really interesting area for further development. I think now we're going to see this more and more. Again, I tell people if you have depression, it needs to be treated, and people with late life depression need to be monitored very closely for cognitive problems. What about diet? A lot of people want to know about diet, and what I say is we're not quite as far along as I'd like us to be in terms of diet. There have been a lot of work over the last 10 years primarily looking at individual components of diet. So either certain vitamins, B vitamins, folate, antioxidants, omega-3s, Mediterranean diet, fats. You hear a lot about certain fats, not other fats, fruits and vegetables, and some metals. I think that, in my opinion, we're still in the middle of trying to figure some of this out. I think that the greatest evidence is really probably here, suggesting that the omega fatty 3s or the Mediterranean diet might have some promise. And I think, keep in mind when we eat, it's a pattern, a dietary pattern. We tend not to eat just individual nutrients. It's really the profile or the pattern which I think can tell us the most. This is some work in terms of the Mediterranean diet. The Mediterranean diet is big on fish and olive oil, for example, and fruits and vegetables, nuts. And so this is some work from Nick Skarmias showing that the more adherence to the Mediterranean diet, the less likely of having dementia, and also, very interestingly, that there are less of the, on MRI, on brain scans, less infarcts, less little changes in white matter and small infarcts, suggesting that this may be one of the mechanisms. It may be that because of vascular improvement or less white matter changes. What are we going to see in terms of nutrition? I think, again, we're going to start seeing a lot of work in this, particularly with this idea of the pattern, so that just not one single nutrient, but looking at different patterns. There have been some medical foods now that are being investigated, either as a drink or as a supplement. And I think we're going to see a lot more interest in this and using biomarkers and imaging to really get at what might be going on. Okay, so I'm going to sort of pause here and say where we are, what can we do? I think at this point, we think that being very on top of some of these things, screening for depression, treating it if it's there, looking very closely at cardiovascular risks and treating those, maintaining the health of the body and the heart. Intellectual and physical activity, I think, are really promising, and there's no downside. So why wouldn't you offer these to patients and to society? Assess for sleep disturbances. Make sure people understand the connection maybe between sleep quality and the aging brain. Possibly a role for diet, we'll see. I think we need much more research and big trials looking at these things, probably not just individually, but together. And I think we need to remember that the brain has been changing and growing since in utero. So we can't just start looking in late life. We need to start looking at the life course and understanding how early childhood, early adulthood, midlife, all could play a role. So you, of course, in Australia are ahead of the game with your wonderful Your Brain Matters initiative. I think this is spot on in terms of what we need to get people to do, and understanding the connections between the body and the brain, staying active. I think this is really a wonderful initiative, and I'm looking forward to downloading the app myself. So I think this is terrific. I now want to turn to sort of the last third or so of my talk, and I think talk a little bit. Some of this is a bit theoretical, but I think it holds great hope and promise. And this is some work we did looking at if we could reduce some of the things we've been talking about, even just a little bit, what would that mean for the dementia landscape? So what we did, this is some work with Deborah Barnes, who's a close colleague of mine. We did this sort of exercise, if you will, was we took 7 of the risk factors that I've talked about, and we said, okay, how much do we think these have to do with getting your risk of dementia? And then if we could estimate that they get reduced a little bit by 10%, by 25%, what would this mean downstream? So first thing we did, and we did this both for the U.S. and worldwide, and so I'm just showing the worldwide results to you. What we did was we came up with these 7 risk factors, and we said, okay, it's a combination of how common these things are, and then how strongly they're related to the risk of dementia. And you need to look at both of these things, because you could have an extremely high risk, relative risk, but if it never happens, if it's only in 1% of the population, who cares? So we looked at both of these things, how common it is, the risk associated with it, and then we came up with what we say is the proportion of attributable risk. How much of the risk of developing dementia could be attributed to this? And what we found is that we think about half of some of the risk of dementia could be related to some of these lifestyle factors. And then what we did was we said, okay, like I said, if we reduce them by 10%, so 10% is in the light blue and 25% is in the yellow. If we could just decrease them 10%, 25%, what would be the effect, downstream effect on dementia? And what we find is sort of remarkable, which is if you could reduce them by, and this is worldwide, if you could reduce all these things by 10%, not very much, I think 10% is something we could achieve, that you would actually reduce the about 1 million cases of dementia worldwide. So that's incredible, right? I mean, just by 10% reduction. And so I think this holds great promise, and it gives me a lot of hope. Now, what's the situation in Australia? Many people do have these multiple risk factors. As I said, they tend to go together. So I think you're extremely well positioned with your campaign to meet this challenge head on, because this is the number of risk factors. And again, these are many of the same ones that I mentioned and that I showed. But you see, many people have 3, 4, 5 of these risk factors. So they're really in a position to, with some reduction, maybe have a big downstream effect. I want to end by talking about something else, which actually Bryce alluded to, which was how far we've come in cardiovascular disease. So this is very interesting, but in the last 20, 30 years, we've made a big dent in cardiovascular disease. And this is, of course, because of public awareness, because of research dollars, because of improving care. We have better interventions. We have better drugs. We have ICUs now, dedicated ICUs. So I think for all kinds of reasons, there's been a decrease in cardiovascular disease mortality. You can see pretty remarkable how this has changed. Part of it is also these risk factor reductions, the campaigns to particularly smoking. So we've come a long way with reducing smoking, and this, I think, is now having an effect. So the question is, well, if this is the case, how will this affect dementia? It could be that dementia could be increased because if we have more people who are living with cardiovascular disease, maybe there's going to be more prevalence of dementia. Or it could be by reducing some of these things, you could have decreased. And so recently, we've seen some very interesting work from the U.S., from the U.K., just came out this summer, the Netherlands, Sweden. And most of these are showing us that if some of these changes are happening, reduced smoking, better use of cardiovascular control, better education in society, we think that there can be, these are small changes, and some are not statistically significant. So, for example, here and in this case, but we think that the trends are looking very positive. That by doing this, by increasing some of these strategies, that we might actually have an effect on reducing dementia prevalence. And I think this is extremely exciting. Part of this was followed up in the Netherlands. They actually showed that the brain volumes were actually higher. So suggesting that there may be something going on here. They thought that much of this had to do with education, changes in education in society, compared to in the 30s and 40s, that things are much better in terms of education. So I think this is terribly exciting. We, of course, have to balance the big push in increased prevalence because of the demographic shifts, and we're living longer. But I think this offers some hope that maybe by getting at the root of some of this thing, by improving education, reducing smoking, better cardiovascular control, we actually may be able to make some big effect. So just to summarize, I think it's very clear that globally we're heading towards an even greater epidemic in dementia prevalence. But we also think that we could have an effect by the strategies that I've mentioned, changes in education, smoking in particular, cardiovascular. We need to start extending this to the life course, as I mentioned. We need to also deal with the changes in physical activity, the epidemic that we're seeing in obesity and sedentary lifestyle. How will these play out? We really don't know. What do we do from now? The progress in Alzheimer's disease is truly amazing. When I think about that, even until the late 80s, people used the words Alzheimer's and senile dementia interchangeably, and in fact, it was thought that Alzheimer's was just normal aging, that this was just sort of, what happened. So think how far we've come. The 80s was not very long ago. So we really are at an exciting time. And I think knowing that some of these, maybe half of cases of Alzheimer's may be attributable to some of these lifestyle factors, we need now this next generation of approaches. I think we need to do the incredible work that's happening in terms of drug discovery. We need to do public health interventions, particularly focusing on education, physical activity, smoking, depression. We need to use the biomarkers and proof of concept. I think having some of the great work that's happening looking in the dominantly inherited Alzheimer's, for example, seeing whether the drugs work in this group. It's like a laboratory, a proof of concept laboratory. Then these can be rolled out. But I think that they need to be in conjunction with some of these lifestyle approaches as well. So I think it's a very exciting time. And I think in the next 10 years, we really will come a long way. There are a number of prevention trials ongoing, including in this country with ABLE. There's a couple in Europe that are very exciting, where these multi-domain lifestyle prevention. So I think we'll hear more about them in the next few years. And at this point, I think I can conclude by saying it's very clear that this is a great need. How to maximize cognitive health, how to improve dementia is a huge public health issue. It's not yet realized, but I think we're on our way. We have several promising, I think, low risk. They don't carry any risk with them in terms of cardiovascular disease management, the depression, physical and intellectual activity, sleep. And now we can sit back and wait for some of these very important trials, and using the biomarkers and the imaging to speed progress, and of course working with the what we hope will be some very good disease-modifying drugs that are on the horizon. I'd like to conclude by acknowledging some of my funding sources and some of my collaborators, and with that I would like to thank you and conclude.